Vad roligt att just du har valt att lyssna på vår podd. Tillsammans så kan vi skapa större möjligheter för förståelsen för integrativ medicin och hälsa. Är du intresserad av det så bli gärna medlem i vår förening och en del av vårt nätverk. Mer information om det här kommer i slutet av avsnittet. Today this conversation are recording at the Psychotherapy Reception Integrative Health in Södermalm in Stockholm. With me as always, my sidekick that keeps me going, the podcast producer Fredrik Ankersköld. My guests today are Graeme Jones. You are so welcome.
Thanks for having me.
Graeme, I have invited you because you are CEO and Clinical Director for Nordic Clinic here in Stockholm and Helsinki. But I see you as a British man working here in Sweden, undercovering for having functional medicine to happen. And I will start to ask you for our listeners to know what Nordic Clinic are. Could you tell us?
Absolutely. Nordic Clinic is it's a group of clinics. So Stockholm is one of 4 clinics throughout Europe, and we're slowly opening more in new countries. But really it's, if you like, a center of excellence for the delivery of personalized medicine.
Okay. And how long has this company?
It started in Copenhagen approximately 15 years ago now. And that clinic based in Denmark was the only clinic for many years until I started working with Nordic Laboratories, which is part of the Nordic Group. And through that cooperation, basically, we decided that it was also time to open an additional clinic, and Stockholm was number one priority for that location.
Okay. How come?
I think it was primarily because that's where I was living.
Aha, so you were living here in Sweden before you started working for Nordic Clinic?
Yeah, so I'd always worked in medicine in various capacities, working with integrative teams and integrative medicine, working in medical screening, working with complex cases, chronic pain, worked extensively in London's Harley Street district with a variety of practitioners. So when I first moved to Sweden, it was really the first time where I wasn't working in some kind of medical clinic. So my goal was I want to get back to working within that environment as soon as possible.
Okay. So how come that you moved to Sweden?
I was living in London and sick of the rat race really there. So I been visiting Sweden multiple times. A good friend of mine was living in Gothenburg, and really the fresh air and nature and the Scandinavian way of living really appealed to me. So I just decided to move.
So you like our Scandinavian way? It's not everyone that does that.
No, but it's I really enjoy it. I like the way of life. It's still quite intense living in Stockholm. Not too dissimilar to London, I would say, actually. But it's easier to get out into nature, and there's a better work-life balance in general. So there was many things that appealed to me, but those were some of the key aspects, just the change of scenery and trying out this way of Scandinavian living.
And now you have been here for 6 years.
6 years now. Yes, just recently married to
congratulations to Victoria.
Poor woman. Yeah.
Poor woman. No, congratulations to Victoria.
Yeah. So it's really when I first moved here, I didn't know how long it was going to be for. Was it going to be months or a couple of years to try it out? But I really firmly see myself staying in Scandinavia.
So I think now we can go into the most important, the most interesting part here, and that is you. How come that you have this big interesting? How come that you have kind of given your life for functional medicine? At least that is how I see you. We have met in seminars and conference, and we have done some cooperation between Nordic Clinic and Integrative Medicine, the association that I'm working for. So where did it start?
Well, it started really from a very early age. I was always interested in sport and wanting to play sport, and that developed into then more, I think, performance and how to perform to, how can patients perform to their very best, and really sparked an interest in the fitness side of things. And then that rolled more into medicine and pathophysiology and how does disease occur. And then it progressed to working in, an environment where I would say I was quite lucky. From very early in my career, I was exposed to pretty forward thinking. So a hospital group called Nuffield Hospitals in the UK, where they decided that the standard medical screening model was actually quite poor, and it didn't do very much for actually stopping disease or trying to reduce the risk of disease. And it wanted to change its focus to doing its best for disease prevention. So very early after finishing my degree, getting into clinical practice, was I exposed to this type of thinking. Plus, I would say to some degree, I've suffered at times with quite low energy levels and possible like burnout or maybe chronic fatigue when I look back on my late teenage years. So it was probably in my early 20s where I really changed how I was eating and living my life, and things happened pretty slowly, but it was quite dramatic. And I still get improvements and still see major changes in my biomarkers and physiology over time through behavioral optimization and change.
Okay. So you kind of developed some chronic fatigue in the late teenager. What do you think was why?
Yeah, I think there was a lot of I had dysfunctional circadian rhythm, and I was staying up way too late, and I was working early jobs. I was quite funny. I was delivering milk in England at one stage as a young teenager that pays pretty well when you're that age, but it involved getting out of bed at some ridiculous early hour in the morning. So I think it was a combination of just that and terrible eating habits. Sometimes I'm surprised I'm not dead, really, growing up on kind of standard English diet.
Yeah, that was where I'm coming to, because my presumption is that I have been in London several times, actually.
Yeah.
And I love to be there, but the diet, my God.
Yes.
You have
really
a lot
terrible.
of different areas that you can find different kind of food, of course, but still.
I think the standard diet is terrible. England has a very broad range of foods and approaches, and that's what also makes it quite interesting. But the general standard of nutrition is very poor, and the general understanding of nutrition is very poor. It's very different working with a Swedish patient compared to a British patient.
It is the similar.
They're very, very different from
very
nutrition.
Different. Sorry, I
starting points. So a lot of my work in England with patients would just be so basic to begin with about what are examples of healthy foods to eat. Whereas in Sweden, it tends not to be at that kind of low level.
So how is the interesting for functional medicine in England?
It's getting much higher. I think England is a bit closer to the US in some ways, because of course this kind of way of thinking or model has been born out of the US and then traveled over into Europe, and it hit England a lot earlier than it hit Sweden. And there are many doctors using functional, even though I think it's a terrible name for what we actually do.
Yeah, what would we like to call it?
Well, I think personalized medicine is a lot better. I think medicine should be personalized anyway. So it's really should just be, good medicine is really about personalizing the approach to the individual. because of course we see a lot of individual responses to treatments or behavioral change, nutritional diets or exercise. So in my, of course, opinion, it always should be personalized as much as possible.
Yeah, I totally agree. That's how we try to work here in this psychotherapy reception. Personalized for every patient, for the unique statement that can be very, very different, or always different, I would say.
Yeah, I think that's where early on in my career, we were giving more generalized advice, and you would get patients that would come back one year later and they'd been really applying that advice and they were no better, or they were worse in some cases. So it really made me question a lot of this kind of standard advice and why isn't it working? Why were my interventions not helping? So I think that was probably in the first 1 to 2 years of clinical practice when I started. And then I really started to understand, as well as it helped, that I had quite forward-thinking people around me in different ways that were really helping to encourage that kind of thinking in a safe way, of course. But
kind of sounds like the best circumstances of science. Were you in a scientific group or something, or what did you do on this hospital?
Well, within Nuffield hospitals, essentially there are many hospitals throughout the UK, and it was a hospital that typically had focused on like musculoskeletal operations or rehabilitation, but it was doing medical screening, and basically it decided to change its approach with medical screening and take things more in a preventative direction, because of course the classical screening tests really are not that helpful. And what I mean by that is that you could have an ECG and your artery could be 90% occluded and the ECG can look normal. So until you had an actual heart attack, then it's trouble. But you could have had an ECG done the month prior that looked totally normal. You can have a lot of different blood results, which I've seen a variety of practitioners not really worry about until they're absolutely abnormal. And we were interested in looking at trends. So not only is it in the normal range, but where is it in the range? Is that applicable that we want it lower in the range in the instance of whatever test it was? So we wouldn't wait for you to turn diabetic. We'd be looking at the facts and figures, and if they're progressing upwards for fasting insulin, if you start to have a HbA1c that really creeps up into the late 30s, starts getting into the early 40s, I mean, we want to be dealing with that much sooner rather than later, because it's so difficult to reverse disease once it's present. I mean, it's much easier to prevent. Yeah,
because this is pre-healthcare that you're talking about, that to develop pre-healthcare. Yeah. Maybe we should say that in integrative medicine and health, we're kind of good to reverse disease as well. I think not always, but we can often do something that is getting the patient to become better.
Yeah.
And I think that is the case why this is growing so much.
I think, first of all, many patients are just so well educated, or they're able to look on Google Scholar or PubMed. They're able to do much more research than they could 10, 15, 20 years ago via the internet. So they can go in and they can look at, well, what does the research say? What's the evidence suggesting? And the fact is that standard healthcare is a slow-moving beast, and it takes a long time to get guidelines changed. So not always, but a lot of the time, the advice can be decades old, and it just takes such a long time to change. So standard healthcare, or the National Health Service, as we call it in the UK, it does take a long time to change guidelines. And I think people now are just not necessarily willing to wait that long. They want to know what does the latest evidence and thinking say? And they want to know more about their own body. They don't necessarily want to wait until it totally breaks down before something has to be done. And this is not to dismiss what the National Health Service does, because I think it's fantastic. And
Absolutely.
we try and cooperate as much as we can. And I have many colleagues and friends that work in the normal service, but it has its limitations. And in England, I think, do a better job at combining both the National Health Service and the private market to really address people's needs. And the reality is that the National Health Service can't do everything for your health. And we're trying to encourage as many patients as possible that they have to take responsibility for their own healthcare. It's your responsibility to look after yourself. And if you don't have good health, then it's difficult having, generally speaking, good quality of life. So whatever your goals are, and I think it's, of course, a point close to my heart, is that people should take more responsibility for their own health. I mean, it would save taxpayers a lot of money if we just take type 2 diabetes, for example, or visits to the Vård Central, 80% of which are for some kind of chronic disease. I mean, even if we could reduce that by 10, 20%, it would be a huge amount of money and time that could be used to focus into other areas, education, or whatever that is. So for me, preventative medicine is really important. And of course, preventative medicine is on this spectrum or continuum that we want to try and use that as much as possible to prevent people progressing to disease that then is going to take a lot of time and resource from the healthcare system. It's going to really affect quality of life. And it's much harder, as we've already said, to reverse a disease once you have it compared to preventing it happening in the first place.
Yeah, that's very true. And in this psychotherapy reception, we also work, I think that a lot of psychotherapists are working like that we are kind of investigate how much motivation the patient have for taking their own responsibility, because you can't develop through a psychotherapy if you don't take the responsibility for it. In the sessions, we do things together, but then the patient have to go out and do whatever they have to do to rearrange their disease or a better mental health.
Yeah.
And better relationship and better whatever they are reaching out for us to do to help them with. And I think that is the same as what you do in Nordic Clinic. So then we take this conversation to Nordic Clinic. What do you do on your days when you are working for Nordic Clinic? Could you kind of give us the details?
Yeah, the days are, well, different and similar. So 3 days a week, usually I'm sitting with patients, and I do some clinical research as part of those days as well. So I work with Karolinska and Stockholm University on a project where we're trying to take 30 participants that have not responded to IBS treatment in the standard system, and they're judged, non-responders. So we're taking 30 participants and then we're using a personalized model to see if we can resolve their IBS. So some of my time is spent doing that. Most of my time is spent sat with patients. So working through their cases, helping, supporting them. And a certain amount of my time is also spent like mentoring and supporting other practitioners in the team, because I also help to oversee our clinic in Helsinki as well. So then it's management things, and that could be anything from just how the clinic runs to key clinical issues, like what interventions or what tests to run on a certain case study, or how to think about a certain case. Because, of course, I have about 15, 16 years of thinking in this way, whereas many of my colleagues have less years of dealing with this way of thinking or this model. So they're learning a new way about how to work with patients that's different to, of course, the standard system, where it's more about the tying of symptoms to a diagnosis and then typically prescribing some kind of pharmaceutical intervention. And again, that's things that we do at Nordic Clinic. We don't abandon that way of thinking, but we add this whole nother layer on using additional tests that tell us more information about how the patient's body is working or functioning, what the microbiome is like, what are their genetics, what are their stress levels, how can we change that. And we use a lot of different tools, from changing of the way patients eat to how they manage stress, or giving them basic tools to exercise, to medication, and to supplements where we have evidence that a supplement is needed. So we're not afraid to use different tools. We're not sitting on one side of the fence or the other. We're trying to find what is the best way to help this patient in front. And some patients, we use a whole variety of different techniques and a combination of approaches, and some we use one.
Very integrative,
yeah,
I would say. So the ordinary patient, you have one of those?
A lot of our patients, I would say, usually have quite a degree of fatigue. That's extremely common, and that won't be any surprise to any healthcare practitioner listening to this, because that's the number one complaint, generally speaking. We see a lot of fatigue, unspecific fatigue. We see a lot of patients that have not been diagnosed with a disease, so their Ford Central has not found anything, but they don't feel well. And then we investigate where might that be coming from. And in some cases, it can be things like viral reactivation, or it can be poor diet, or it can be microbiome disturbances. So we're doing a lot of detective work all the time. We get a 36-page questionnaire on our patients even before they come to the clinic. Yeah. 36 pages.
Oh,
if they're prepared to do it, they don't have to do it, but 99% of patients do it. So fatigue is big. Patients that don't have a disease but don't feel well, they're a big part of our group. We get a lot of digestive disorders, mostly IBS, but some inflammatory bowel disease as well. Skin conditions, we get ME, CFS, so chronic fatigue syndrome.
What is CFS?
Well, it's a condition which is really only diagnosed mainly through ruling out of many other factors. And there's not many clinics in Sweden that work with that alone and that can give that diagnosis. So it's quite hard to get that diagnosis, but it is a really horrible condition where any exertion by the person who has that condition usually then results in further exhaustion, flu-type feelings. They just basically find it hard to do very much and feel really terrible in the process. And I can't think of anything worse than that. And it just goes on. And there's been strategies like pacing, which again has maybe been incorrectly applied, and these group have been kind of marginalized, that it's all in your head and there's nothing going on there. And really there's still a lot of research that needs to be done. But it's a very misunderstood condition.
Is that the same as the Swedish diagnosis name as myalgisk encephalopathy?
Exactly.
Okay.
Yeah, so the ME.
So we had a podcast about that for 2-3 times ago with dietitian Marina Olai, who's working that on Kliniken.
Yeah, I've met Marina.
Yeah, okay.
Yeah,
good.
Yeah,
She's
I
wonderful.
met her before she went to work at Brigare. So we had a little bit of interaction.
Okay.
But yes, she's a dietist with interest in that condition.
A big interest.
Yeah. And we've had different chats about dietary approaches for that group. So we see patients with that and look at a variety of factors that can drive that condition. And we see a lot of autoimmune patients variety of autoimmune diseases, mostly of the thyroid. That's the most common, say, that we see. And of course, a variety of other things like sleep issues, low sex drive, for example, burnout, and some other things. But I would say that covers quite a lot of the type of patient that comes to the clinic.
So kind of the complex and chronic statement that a lot of people have in our lifetime. And post-COVID, have you started to see them?
Started to see a few of those patients, and we see some similarities with post-viral fatigue. So I believe I've written a little bit about this.
Where have you written about it?
Because I'm a guest writer for Food Pharmacy.
Okay, so if the listener want to read whatever you have written, where can they find it?
You can either go to like Food Pharmacy's webpage or Nordic Clinics as well, because we put the blogs on those both pages. So I've talked a bit more about that, with the leading theories being like changes in the microbiome or some development of autoimmunity or reactivation of latent viral infections, particularly the herpes family of viruses. So with those post-COVID patients, we've been certainly doing and finding some interesting results with viral reactivation and microbiome changes.
Then you can see results already now.
I would
by
say
experience.
With specific post-COVID patients, we've not been seeing enough, but yet to really kind of give that a very kind of solid statement. But I've seen a lot of post-viral fatigue patients in the past, and had a very good number of them improve after similar type treatments. But of course, it's not always like a guarantee. I mean, we're always saying that to the patients, that we have theories and ideas and we can explore these. Doesn't mean that we're going to get results or we're going to solve the issue in all cases. I mean, there's still huge gaps and a lack of understanding even in personalized medicine, and it's not for every patient. Some patients don't respond well to it for a variety of reasons, that they're not prepared to make the changes, being probably the number one. But I think, of course, fundamentally, we are really using behavioral change to improve health. So I think that's important. If you're thinking about going to personalized medicine for help, you're going to have to be prepared to change how you think or how you sleep or how you manage stress, how you eat. And that can take time. And it's going to take effort, and it's not going to change all at once, but
step by step.
Yeah, so step by step and little by little, it all adds up.
Yeah, that's true. It's a work, but it can be a very fine work. You can get, when you're getting results, because I think that I told you before we started this podcast that many of us who have been here in the podcast have made our own experience about this and why we are so interesting about this. As you told us in the beginning, that you made this food changing and you're starting to get more energy and so on from a pre-fatigue in a late teenage aging. And that's often what happens. The hard thing is to people to get there, and then you have to go your own process before you're coming.
Yeah.
So, but how, if a listener is listening now, how can they come in contact with you and the reception? Yeah,
different ways. I mean, they can reach out via email. So info@NordicClinic.se, or they can call us, but I can't remember what the phone number is off the top of my head.
But maybe they can find it on the website.
They can go to NordicClinic.se and all the information is there.
So how many are you that are working there, and what kind of professionals are they?
We're around 16 people. Some, of course, are based in the administrative side. We have 4 different medical doctors.
With different specialties.
To cover different areas. And we have 2 nutritional therapists. We have 3 health coaches. We have a researcher, because we've also been doing research looking at how our model works to improve outcomes with patients. Again, that was something I've been wanting to do for a long time, to really start to demonstrate how does this model work? Can we show that it really improves quality of life? Because we all anecdotally, we see that patients get better. I wouldn't have been able to grow this clinic if patients didn't get better, because initially it grew a lot through word of mouth. So we know that we're doing some things right, but of course the key questions are, where are those key things, and where does the model need to be improved? And where could this possibly have broader applications in medicine, in the general system, which of course is the long-term goal, is to try and show that this way of working and thinking, it may not be right in all areas of medicine, but probably for prevention and probably for chronic diseases, a lot of the time it has more answers than just necessarily just using medication. And that's not to say this is not one or the other. It's we combine this with medication patients are taking, and sometimes that means they can come off medication with the right supervision, of course, and when the time is right, and sometimes it doesn't, but they get great improvement by combination of approaches. And we can't do everything. Also, I can't know everything. Doctors can't know everything. We need different specialties to be able to work together and get the best knowledge and information for different conditions and problems. So I think that was one of the things with the clinic, was it needed to be a multidisciplinary clinic, to have different specialities around behavior and lifestyle in particular, because that's where we are fundamentally trying to make a big difference.
True. And what you say, that I'm thinking that this is both and instead of either of, as this podcast name is. We need both. We need a lot of different perspective, a lot of different knowledge and so on, to find the personalized healthcare, best personalized for the specific patient.
Yeah, absolutely.
So you told us in the beginning that it was you're in some study now on Karolinska Institutet.
Yeah.
Are there any studies going on in England, London, or Helsinki?
No, there's no studies going on there. So at the moment, Nordic Clinic Stockholm is the only one doing research out of our group of clinics. So we have a clinic in Portugal as well, in Porto. Mm-hmm. And we're hopefully going to be opening soon in Iceland and Croatia, and
wow.
Possibly London as well. We'll see. But that's the plan, is to can basically grow the team throughout Europe, but just have these centres of excellence where we can demonstrate how this model works for chronic disease and for those patients that want that help.
So are you going to be director for those reception as well? Those clinics as well?
Yes.
Yeah? Wow. Yeah. You're going to be even more busy.
Yeah, a really bad idea. Yeah, I think it's very exciting to work with such a range of different personalities and specialities, because, for example, we have a neurologist in Croatia. We have a sports medicine doctor in Porto. We have Cecilia Tabell, an endocrinologist in
she's been
Stockholm.
Here in the podcast twice, actually.
And we have these different specialists, and we have different nutritionists all over Europe that really, I think it creates such a rewarding environment in one way, because you're learning all the time through different experiences and different viewpoints. I think that's what I'm really trying to do, is work on this model of personalized medicine, bring all those people together from different countries, show how that works, and be able to, hopefully we'll be able to do more research throughout all of the clinics eventually. And then we can really start to get bigger data cohorts, and we can look at outcomes for various conditions or diseases that we're working with. And it might be that some of the team get much better results. So then we need to learn by that. why are they getting better results over there, and what can we take away? And of course, some of that is clinical intervention, some of it's soft skills, like how the bedside manner, so to speak, of certain doctors or practitioners. And I think that's also important with the process of getting better. You don't want to be working with someone who is not personable at all, or rude, or has no empathy. I mean, it makes it much harder it's also speaking as a patient who've been and tried to work with different doctors at times. And so I think it's more difficult when there's not that relationship there that's supportive and understanding and empathetic, and someone who can communicate with you on a level which you understand.
That's awesome. So today, are you working like that? If you have a problem, you have an issue with a patient, you can consulting doctors in London, England, Portland?
In Portugal.
Portugal.
In Porto.
Sorry, I didn't hear that. Portugal.
Yeah, Portugal.
Can you consult doctors there and in Helsinki and here in Sweden? Or can those doctors from here, Cecilia Tebelles, for example, can they sit together and have a conference or a conversation?
Yeah, I mean, we, like tomorrow, for example, I will deliver training to the whole group of clinics throughout Europe, and we'll get different insights and opinion on certain examples of cases. So, of course, we were always discussing various issues, and that could be more general topics, or it could be we have an example of a patient case that either the patient has given us permission to discuss it with the group, or we remove, of course, any identifying features from that case, and then we can discuss it internally and see what ideas the group come up with.
So if a patient come to you for help, because I haven't heard this about anyone that have been having those conversations with during this 21, 22, 23, maybe 24 when this is sending, during this podcast, that patients that are coming actually can have other doctors, other practitioners from other countries to solving the problem. Because if they have gone for a long time with some chronic or complex statement, they actually can have professions, specific professions from other countries as well. I have never heard that any clinic have this.
Well, it's not that it's not a paid service. So it's not like they're coming to us in Stockholm to have an opinion of whoever that is in another country. But of course, we have a network of extremely talented practitioners. So it's not unusual when we get these complex cases, and if there's a patient with a neurological condition that, and this happens where we're trying to refer that patient for further neurological examination in Sweden, and they won't take the referral, which is really challenging. I mean, I hadn't encountered that before being in London, where there's always, even though you weren't joined with all these other clinics, but you would have your network of specialists that we would refer to for opinion on cases, and they would always welcome those cases, look at what we're asking, give their specialist opinion, and refer the patient back to us. So I could often be sat in the middle of that spider's web, where a patient may need to see the surgeon and see a specialist physiotherapist, maybe go to a gastroenterologist or an endocrinologist, might need 4 different opinions on what's going on, and then we would sit in the middle, like of course a general practitioner would do in the normal system. But of course, in the normal system, it's going to be very hard to get that amount of referral, generally speaking. We do where we have, also work with some professional athletes and in Sweden. And if there is an issue where we need a sports medicine doctor opinion, then I've got the ability to go to the doctor in Portugal and ask a question about certain symptoms or issues, and we're going to get a very specialist opinion. So I think I've always done that naturally. That's a normal thing for me. That doesn't feel strange to really talk about. And I think everyone in medicine probably does that as well. to a certain degree, because you're always asking colleagues or sharing information, not directly about patients, but it's like, yeah, I'm working with a patient with X condition or issue. What do you know? What have you done where you've had troubles with this or that? But yes, we are more and more developing the Nordic Clinic network and how we can all learn much more effectively from each other across different countries. But in London, we always used to have, so I worked at a chronic pain clinic there. I mean, we used to have monthly clinical meetings on problematic cases, and the neurosurgeon would be there with the radiologist, and we'd have the physiotherapists and the corrective exercise specialists, and we'd have a whole variety of expertise around the table presenting these hugely problematic cases, get a lot of different opinions, and then we would get an action plan. So this patient that hasn't responded to these 10 different things that have all been tried, what options are still available? What's the radiologist's opinion? What's the surgeon's opinion? What more can we do here? What was my opinion? And it would be incredibly rewarding and productive, and it could solve a lot of troubles and issues. We would come up with new ideas, and it was really a cool thing to be part of, to see all that expertise really trying to help each other and ultimately to benefit the patient.
I can really understand that. Very stimulating for you as a as a therapist as well. I agree that, of course, we, no matter what we are working with, are asking our colleagues and other professionals about patient that we need to discuss in some way or so. But it's kind of another level when you can also ask professionals from other countries, because we have our social constructions, our guidelines in different countries and so on, that is different from another country. So, and with that, we can think in another way. So it kind of even gets more a higher quality when you also can think out from the box, because you're speaking to someone else that have other guidelines, that have other way of thinking and other way that they have taught something, knowledge about whatever they're working with. So I think that is very, very Socratic, and everyone that has listened to this podcast know that I kind of love Socrates.
Yeah.
And dialectic. And I think this is a very Socrates way to speak about certain issues.
Yeah. And we might not be able to apply some of the things that they're suggesting because the Swedish system doesn't allow it, or it's controversial, but it's still always an interesting learning process. I mean, there's just so much evidence out there and research, and unfortunately, many doctors don't really get the time to go through it. I mean, most research is written for other researchers, and it doesn't trickle down usually very well to those that are making the clinical decisions in the day-to-day practice. Yeah, so, true. Of course, a lot of things, I mean, wasn't so long ago where I would have doctors think I was crazy for talking about the microbiome and the importance of gut health for overall health. And now that's a lot common. Yeah, it's less contested, yes, at least.
And we have been with that. We have been part of doing that work to bring out that knowledge.
Yeah.
And I think that is amazing.
I think for me, it just makes sense that we have all these different systems in our body, and they're all working together as a whole. So to say that the body and brain are totally separated, or the fact that our hormones don't talk to our gut bacteria, or our gut bacteria does not talk to our brain or our mitochondria. And we clearly see now there's much more research which shows that is the case.
Yeah.
That bone health is important for gut motility, for example.
Yeah.
And these things have really come more and more to light. That we have a lot of these bidirectional axes, where we have this bidirectional communication between different parts of the body. So we can't just think of things in isolation.
True. So from this, where are you? You told us that you're opening new clinics in Iceland and so on. You're the clinical director. Where do you want to take this Nordic Clinic? Where are you heading?
Well, it's a great question. I mean, we're just really trying to spread the word and raise awareness about this model, about that we think that healthcare, especially with chronic diseases, it needs to change. It needs to move more with the time. Doctors need more education about nutrition and behavior and lifestyle. So we're fundamentally just trying to really raise awareness and show that this works. And that's what we've been trying to do for a number of years, and we'll continue to try and do that.
And by proof, it have worked. So you just continue your work. So our time is running up, but I want to ask you before we are stopping this so interesting conversation, if there's something else that I haven't asked you about, that we have been speaking about, that you want to bring up in this conversation for our listeners, what do you think is important?
No, I don't think we've covered all the key bases. I think it's just to really highlight that, again, our body it's a system of systems. We really like this biopsychosocial model, which has been around for a long time, yet hardly gets well applied in medicine. So we specialize mostly in the biology. We do have a psychiatrist on the team, actually, Nordic Clinic. So Good. We do some small things there. But of course, the social aspects, the mental aspects, or the emotional aspects, I mean, they're big, huge parts of health as well. We know things like social isolation is probably one of the worst things that you can have for your long-term health.
It's very deadly, actually. Yeah. It's very deadly.
So it's not just, again, I see a lot of people that think that they are healthy because they eat well, but they don't have great mental well-being, or they're not, or they don't have great fitness, or they're not thinking about it in the whole perspective. And of course, that's totally understandable because we've not been brought up that way. But for most of us, and I wasn't either, but I think it's just important to remember that we are a biological systems of systems. There's different components to our health. And it makes it much more difficult to think about all those things, but that doesn't mean that we shouldn't try. And it doesn't make it too complex. It's one step at a time. We
cannot not think about that.
Yeah.
And I would like to add as a psychotherapy, because I think that my approach to patients is that I include the body, and I'm a licensed nurse in the bottom. So it's come natural for me. But I think that it's as a living system, your inner living system, your body's system is totally connected with everything else through relationship in a intersubjektiva fältet, as we say in Swedish. It's also happening in our system outside the body, and everything that is happening outside the body it's affecting the inner systems in the body. So I think that is also something we could just see in this pandemic, how our mental health is very much worse now than before. It was worse especially here in Stockholm before this pandemic. It has getting worse during the pandemic. And it's because of everyone has been so frightened, and many people have been alone.
Yeah.
So that is also very much. And then we can see that because in adrenaline or cortisol or whatever, we can see that in blood tests, that they have been very alone because they are getting stressed and they can't regulate themselves by themselves because we need other people to do that, and so on. So this is complex, and that what I think that we professionals, that is working with this, we are the one that has to understand this.
Yeah, exactly. And it's just important to understand the big picture. Again, it's just taking supplements doesn't mean you're going to be healthy. Far from it. You can't out-supplement poor mental health or social isolation or poor fitness, just as a few key examples.
Yeah.
You've got to make changes. You've got to consider all factors And of course, that's not easy to do, but we have to try.
And it's so worth it.
Yeah.
Graeme Jones, I'm so happy and honored to have you in this podcast. Thank you. I hope I can invite you sometimes
Absolutely.
in the future again.
Thank you very much.
Thanks. Både och istället för antingen eller, en podd om integrativ medicin och hälsa är skapad och drivs av Svensk förening för integrativ medicin och hälsa, FIMH. FIMH är ursprungligen en yrkesförening för legitimerad vårdpersonal. Vi representerar sjuksköterskor, dietister, fysioterapeuter, läkare, psykoterapeuter, psykologer, tandläkare för att nämna några. Idag omfattas våra medlemmar även av associerade medlemmar som inte behöver vara legitimerade. Föreningens arbete vilar mot den vetenskapliga grund för integrativ medicin och hälsa som finns, såväl svensk som internationell, och på systemisk förståelse av människan i sin miljö. Vår förenings arbetssätt har hittills varit att arrangera konferenser, seminarier och folkbilda genom att sprida information, exempelvis via sociala medier. Vår strävan inom integrativ medicin är att vara en organisation som vågar lyfta och ifrågasätta, motverka polariseringar genom tvärvetenskapliga dialoger och sokratiska samtalsregler. Vi vill kartlägga forskning som bedrivs även internationellt och hålla koll på aktuella forskningsresultat om behandlingsmetoder, både vad det gäller den etablerade vården liksom den vård som bedrivs utanför den etablerade vården. Sokratiska samtalsregler innefattas i den sokratiska samtalsformen som egentligen all grundläggande kunskap är sprungen ur, men som ibland till och med lyser med sin frånvaro i dagens public service. Så bli gärna medlem hos oss, för tillsammans kan vi förändra. Och hur du blir medlem hittar du via vår hemsida integrativ-medicin.se. Vi ses och hörs i nästa avsnitt.